So if you use the ADA guidelines, it can't be emphasized enough that you can't forget about lifestyle modification. That it's not a series of steps that if you fail one, you abort it and chuck it. It's lifestyle modification followed by initial medications and so on, and then you add to it. You don't substitute or switch around like you sometimes do in treatment of depression. You know, you start with the treatment, provided there's no side effects, it's additive. Then you're adding things on top of the previous one and reinforcing the ones that you've already done, like the lifestyle modification. Smoking cessation is huge. Weight reduction, physical activity, and lowering salt, all things that make sense. Pharmacologic therapy, which we'll get to a little bit more in depth here in just a second, talks about ACE inhibitors, ARBs, thiazides, beta blockers, calcium channel blockers, and the fact that multiple drugs are generally required. Case in point, you look at these different studies, right? Each one of these numbers down the right side represents the number of antihypertensives that's required to get people at the goal. The goal being whatever is set forth in the study itself. You know, in this one, they're just shooting for under 150 over 85. So here we're looking at mean arterial pressures or diastolic pressures below 80. And on average, somebody has a pressure, or the number of medications to control their pressure is about 3. So it takes multiple medications to control these patients. So don't be afraid to add stuff to it. That's a common mistake, especially starting off early in residency, is a tendency to switch. And you do not want to do that. So talking about different trials, this particular slide is a little bit misleading because it goes back to the UKPDS, and at first it looks like there is a preference for beta blockers. The problem is the margins of error in there overlap and they're non-definitive. They're not statistically significant. So there is no favorite between an ACE inhibitor and a beta blocker, despite the fact that those midpoints are actually slightly over on the beta blocker side. When you look at a meta-analysis from all these different studies, and I'll kind of skip over this, it focuses on different medicines, different ACE inhibitors, comparing to calcium channel blockers, diuretics, so on and so forth, and we get to a couple different slides. One, ACE inhibitors do reduce myocardial infarctions. They do reduce cardiovascular events and mortality, but not necessarily stroke. Okay, that's one point that they came to a conclusion of. Now, is there a superior one? By now, most of you probably should have heard that the first medicine that you should put a diabetic on is an ACE inhibitor or an ARB, correct? Okay. Most people prefer ACE inhibitors simply because they're cheaper, whereas an ARB is a good medicine, but more expensive. I think they got some generics coming out in about 4 or 5 months. I think they're going to have the first ARB that's going to come across, so that'll be a good thing. When you look at all these different studies, if you ever did a Venn diagram, if you're really anal retentive with math, you could figure out ultimately from all of this that ACE inhibitors are slightly preferred. But the point is, there's no magic bullet. When you're looking at just the blood pressure control itself, one agent is not clearly superior to any of the others. It gets murky, especially when you throw in different ethnic groups. Thiazides have responded very well in African Americans, for instance. And so it's hard to say with definity that one is better than the other. But to protect you from microvascular disease, that's where those ACE inhibitors really come in, protecting the eyes and the kidneys, the smallest blood vessels in your body, that's something that really should be first line. So then second line, what do you go with? All-HAT trial was a real big one that focused on thiazides more than anything else. They tend to be complementary to your ACE inhibitors and ARBs. You get a little bit thrown off on your glucose metabolism. That's worth noting that thiazides and blood pressure and niacin and cholesterol both can tweak and raise your blood sugars. So just be cognizant of that fact. Beta blockers, not really complementary, but on the other hand, they have their own set of benefits, especially from a cardiovascular standpoint. That people who have CHF or coronary disease, they improve mortality outcomes. If you've had a prior cardiac event, you should be on a beta blocker, and you'll see people come in with this itty-bitty doses because they have low pulses and stuff, but they put them on it anyway because they show higher survivability rates. So then the treatment algorithm is just a graphic analysis of what we've been talking about. Always start with the goal in mind, the lifestyle interventions, smoking cessation and such, and then you go down a series of algorithms starting with an ACE inhibitor, followed by beta blocker, thiazide, ARB, so on. Additional recommendations. Again, you have to tailor each person individually. And the ADA guidelines very clearly say that as well. Lower blood pressure gradually in the elderly. A lot of geriatric guidelines start saying that the pressures really should be in maybe the 140s. So you need higher cerebral perfusion pressures as you start getting hardening of the arteries and ischemic changes that happen naturally over time. So the idea that everybody should hit a blood pressure of 130 over 85 really is erroneous. You have to tailor it to each person. You're not going to shoot a 95-year-old trying to get their blood pressure in the 1-teens. You actually want it higher than that. You have to check for orthostasis, especially depending on the medications like the beta blockers that they're on. If the angiotensin modifying drugs or diuretics are used, you have to watch the renal function and potassium. That's something that tends to be really tricky. I'm sure you probably have a lot of diabetics that are now on dialysis, and that takes away a lot of classes of medicines with diuretics and ACE inhibitors. So that can be certainly problematic once you have to eliminate meds. And you have to use as many medicines as necessary. The idea of polypharmacy is actually crucial in this sense. It gets lambasted by side effects, but you have to use as many as you need. Resistant hypertension. Focus on sodium intake. Often improper blood pressure measurements. Keep in mind your diabetics are frequently larger individuals, so you have to get the right size blood pressure cuffs and just look for the logistic errors that can sometimes happen. Inadequate diuretic therapy, there's going to be another slide coming here in just a second that focuses on that. And as I've been saying, you do tend to retain the fluid. Even if you don't get edema from it, you tend to get a higher amount of fluid in the blood vessels themselves, leading to higher pressure. Medications can obviously be inadequate doses. They could be doing something like taking methamphetamines or whatever that's raising their blood pressure, so you have to look for things outside the box, alcohol intake, and then other things like pheochromocytomas or other zebras like that. This is the slide that I was referring to. So I don't routinely put my patients on spironolactone. You know, that's not one of those things you're like, okay, I think I'll put you on that to knock your blood pressure down. But the fact is, these people in this particular study were already on diuretics, like a thiazide typically. And so in the interest of retaining some potassium levels, they get put on this, and we look at the x-axis, which is the degree of improvement or the blood pressure response. You see a pretty sizable systolic drop among both African Americans and whites with the addition of spironolactone. That there's kind of a lag in that 3-month area between the different ethnic groups. By the time you get to 6 months, both the diastolics and the systolics have regulated to the same point, and they both showed pretty meaningful changes to the point of 25/10 difference in blood pressure. So whatever agents they were already on, including HCTZ in the most cases, you get an additional improvement with the additional diuresis. So something to keep in mind on your diabetic patients and the heart failure patients is, are you adequately diuresing them for the management of their blood pressure? So then we go over to lipids. We're in the home stretch. So you guys are doing great. We're almost done. LDL recommended less than 100. Under 70 for patients high risk. Typically cardiac patients, people with stents and prior cabbages and such, most cardiologists shoot for 70. HDL greater than 40 or 50 if you're female, and triglycerides less than 150. Basically, this just shows that there are different scales, but they pretty much line up.